have mainly two types of the immune response, the adaptive immune response and the innate immune response. And most of the therapies, probably all therapies in UC treatment, are directed towards the adaptive immunity. So this means towards blocking lymphocytes in some way. But we have no therapies, no medical therapies for the innate immune system. Just GMA, the granulocyte monocyte apheresis, has been described to be acting in the monocytes and the neutrophils. So, well, this is a different approach for the treatment of UC, and we have been exploring this option probably in two different settings, mainly in the steroid-dependent UC, but also in combination. So I think this is very attractive that we can think on, well, we can treat one system, one part of the immune system, but also we can use an add-on, the DMA, to serve as an additional therapy and to provide more options to this patient. We have recent data from the last ECO Congress showing that with the different target therapies with biologics, but also with small molecules like tofacitinib, the innate immune response is overrepresented in those patients showing a primary no response or a loss of response to these therapies. So, well, this highlights the mechanisms of action underlying this loss of response, and this should serve as a red flag that we need to do something else in some patients, as we are going to have a lower probability of achieving clinical or endoscopic response. So probably GMA, if it's focused in these neutrophils and the monocytes, well, probably this is attractive to serve as an add-on therapy or a combination therapy in some of them. I've been going through two main topics in my presentation. The first one is to demonstrate the role of the innate immune response in those patients, more refractory patients, who are not responding to one of these biological or small molecule therapies. And it is interesting to see that each of them are demonstrating that non-responders have an overrepresented neutrophils or monocytes. So, well, we should look more into this detail about the mechanism of action underlying these non-responders and the role of the innate immune response. The second point in my presentation was to show, well, if this is the main mechanism of action underlying these non-responders, how can we apply GMA, the granulocyte monocyte apheresis, into this combination therapy as an add-on therapy. So, well, I've been going through all the combinations, all the possible combinations with anti-TNF, vedolizumab, ustekinumab, and tofacitinib, and well, we have demonstrated that it is safe. That's the main thing, but also it can show a benefit in terms of clinical response and clinical remission of these patients. So I think it's very attractive, and I'm sure that in the following months and years we're going to see more data about this.